A very good evening and a wonderful Sunday. It is the beginning of a new month. It is the very first of December, and I'm so glad you've joined us today on the Weekend Edition. My name is Nora Osende. Well, the Weekend Edition is where we get to discuss some of the pertinent issues that are making headlines in our country. Now, being the first day of the month, not just any month, but the first day of December, we get to celebrate the World AIDS Day. You and I do know that AIDS or HIV/AIDS has affected so many families in Uganda and the world over. Not just families, but individuals and communities. One way or the other, someone knows someone who has been affected by HIV/AIDS. You and I know that we have been affected, not directly, indirectly, or in so many ways. And that's why on this special day, we get to celebrate and acknowledge the World AIDS Day. And because of that, we have a doctor in studio who is going to discuss with us about the World AIDS Day and the strides that the government has made in combating HIV/AIDS, the challenges, the achievements, and all these other things that we need to actually discuss a little more about HIV/AIDS. Well, in studio with me, I have Dr. Maureen. Dr. Maureen, you're welcome.
Thank you.
Dr. Maureen is from the Uganda AIDS Commission. Kindly introduce yourself and tell us exactly what you do at the Uganda AIDS Commission.
Hello viewers, hello everyone. Dr. Maureen Kwikiriza. I work with Uganda AIDS Commission as the technical officer for adolescent girls and young women, stroke adolescent boys and men, and the Department of HIV Prevention. Uganda AIDS Commission was formed by Act of Parliament in 1992, whose mandate is to coordinate mainly the multisectoral coordination of HIV response in the country, after our president realized that HIV/AIDS, as Nora already introduced, that really was affecting us individually, or family level, community level, and even as a country, even at workplaces. So because of that political will, he noticed that HIV is not only it's not only affecting health, but it's affecting all the sectors, psychologically, economically, socially, even politically. Because if you have the soldiers and they are dying, then, or if you have the policymakers and they cannot be able to sit and enact their policies because of the illness. So we noticed that it's affecting all the sectors, and therefore we need a multi-sectoral approach towards it.
Right.
Yeah.
Now, with that introduction, clearly, I think we are going to dig into the ongoing celebration that just happened today. Tell us a little more about the theme of the celebration of the World AIDS Day today in Uganda that happened in the eastern part of the country, that's in Buyende, right? And what exactly, how does it resonate with the fight against HIV/AIDS in Uganda, particularly?
This year's celebration, World AIDS Day celebrations, are in Buyende district.
Yes.
In the eastern part of the country, particularly in Bukungu sub-county and at Bukungu Primary School. And it's going to be presided over by His Excellency, the President of Uganda. This year's theme is accelerating interventions to end HIV/AIDS by 2030. And also, in addition, also a campaign which we are running, led by Uganda AIDS Commission, is Wear the Ribbon campaign. So as we are wearing the Red Ribbon campaign, it's an indicator for you to remind you that we have HIV/AIDS, it still exists, and also to stand with the people who have been affected or infected by HIV/AIDS. So going back to our theme of accelerating interventions to end HIV/AIDS by 2030, by the fact that we're using acceleration, it means that something was already being done, but now we need to step up what we've been doing, because from we are now in 2024 to 2030, those are like about 6 years remaining. So we can't start doing business as usual. We have only 6 years So we need to accelerate, to add in more gear. If you are driving a car and you are going at speed 10 or 10 kilometers per hour, now we need to go to 40 kilometers per hour or 80 kilometers per hour.
Oh, okay.
Yes, so that we are able to get there. We see that 2030. In 1992, 2030, when they formed the commission, 2030 seemed very far.
Oh, yes.
But now it's very near. So meaning we need to step up our efforts.
Yes.
Yeah.
Talking about stepping up efforts, Uganda is one of the countries that has been commended for the wonderful achievements in regards to the fight of HIV/AIDS. And world over, really, it's a very exemplary country in that regard. Let's highlight a little more about the achievements that we have so far.
I think all of you, the new generation may not notice, but people who are maybe of my age and older, they can see actually there has been an achievement, because in the early 90s or even 80s, when the HIV, we realized that we had HIV/AIDS as a pandemic, just telling someone that you're HIV positive, it was equivalent to a death sentence. People lost hope, but which is not the case today. There is hope. So we've seen the prevalence decrease from over 10, when it was over 10%, to now, by statistics of last year, 2023, up to December 2023, shows that we are at 5.1%, which is a great achievement.
5.1%?
Yes.
From
over 10% in the beginning.
Oh, wow.
So, which is a great achievement. But also, we've seen the services reach up to the lower level. You can, I don't know, for those who are old enough, you remember that testing, even just getting an HIV test, you didn't get your results that same day. And besides that, you needed to walk a long distance to bigger hospitals to have that test. Then they tell you, wait, come next week to get the results. But now we can see that you have an HIV test even at the comfort of your home. We've introduced, besides the routine one, which is blood, the assays which are done in the hospitals, but also we have what we are calling HIV self-testing. You get the kit. For people who are very busy, who cannot meet the working hours of the health facilities, and you test it at the comfort in your home. And there is also hope, which is, I think, is an achievement. Before, people were dying more. I want to believe they were dying more from depression, more than the disease. It's the disease-related complication itself, because they didn't have hope. It was what next, but now we have hope. They are ARVs, and we can access ARVs even to the lowest health facilities, health center 3s. We have community distribution points, which are reaching the local person in the community there who is not able to come to the big hospital. So, and because of that, when we look at our data, we look at our statistics, we can see that right now about 92% of the population, they are aware of their HIV test. At least they have ever tested, and they got to know their results. Oh, yes. And those who are found to be HIV positive, we see about 90% starting on ARVs, and they are able to live a better life compared to before. Right. So briefly, that's what I can highlight, and I can say all this has been made possible because of the political will we have, especially because we see that the president and the first lady, they have been much into this campaign or into this HIV response. Yeah.
I would like to dig a little more into some of the factors that are actually contributing to this percentage drop. I think you have hinted a little more on within there as you were talking about the achievements, but you could actually dig a little more into some of the things that we are doing now that we weren't doing in the past that have contributed to the drop of the in the HIV/AIDS prevalence rate in Uganda.
As time went on, when we were hit at the beginning, let me say in 80s and early 90s, we didn't have, the science was less, we didn't know much. But along the way, we've had evidence-based interventions or solutions. Right now, okay, at the beginning we relied on ABC, abstain, be faithful, and then use a condom, which we still say they still work, but then now we've added on, for those who are already HIV negative, we've added on what we are calling the D, ABCD, which stands for drugs. So for those who have been at risk, or if you feel you're at risk and you're sexually active, we have drugs, what we are calling pre-exposure prophylaxis or PrEP, which is available. But also those ones maybe who have had accidents and there has been a mix of blood with an HIV positive person, accidents like maybe a needle stick injury, or you've been defiled and raped and the other person is HIV positive. We have what we call PEP, post-exposure prophylaxis. And for the women who are in reproductive age and they're HIV positive, initially, remember those days, if you're HIV positive, you shouldn't get pregnant. But right now, we say there's hope, the future is bright. You can get pregnant and have an HIV negative baby because there are also drugs for that. There are ARVs for the mother who is HIV positive, but also for the baby who is going to be born. And we are seeing now, also we are getting now, fewer babies who are getting HIV infection at birth or during delivery, or during breastfeeding. Because, so what I can say, what has contributed to that drop, one, is we've had evidence-based interventions and solutions which have been scaled up to reach everywhere, to reach the communities, to reach everyone who is in need. But also there is awareness in terms of the the different HIV prevention modalities, so that for those who are HIV negative can remain negative. And also the ARVs. So when the person who is HIV positive takes the drugs, and the amount of virus, what we are calling the viral load, is reduced. Also the risk of transmission is reduced, what we are calling that prevention with the drugs. So all those ones are contributing to the reduction in the prevalence of HIV infection.
I really see how this helps in the reduction and contributing to the reduction in the HIV/AIDS prevalence. But on the other hand, someone may also argue and say that partly the reason as to why some, especially some age categories right now, are complacent, or they don't really mind, about HIV. They're not as scared as they used to. It's because of the prevalence of some of these things you've mentioned. How do we help such people, really?
How we have to help these people is to continued messaging. And actually,
because you'll find a young girl saying, I am afraid of getting a pregnancy than HIV/AIDS. Because with HIV/AIDS, I know I can take my drugs and I will live for long. And it kind of gets them into that mindset, really. Yeah. And yet this, at the same time, is actually helping people out there. But someone may use the same information in a different way. Yes. Yes,
I get it. And I think we've been reviewing, looking at our data, looking at our programming and our HIV response, and we notice, and yet we cannot continue with those messages which we started with, like AIDS kills, because sometimes it stigmatizes.
Yes.
So, but what we can do is to continue messaging which are targeting those people who feel they are not at risk. We've been able to review our messaging, and also we've been able to have now what we are calling a combination prevention package. That not one method is enough, it's a combination of things.
Yes.
So from the messaging to biomedical, to structural, to involvement of communities, the parents, the caretakers, so everyone that we join efforts. As the medicine, the biomedical or the health workers are doing their work, we also have the structural, but also looking at the behavior, so that what we are calling biomedical intervention, a combination of interventions which are working, including the messaging, still telling people, we still say HIV is still there, it still exists. And someone's HIV status is not your status. Now, because there have been an evolution, it's not scary like those days you'd see someone who is very sick with all these complications. Sometimes now the new generation is not able to see that.
Oh, yes.
So what we are telling them, you cannot now test for HIV with your eyes. No. So we are encouraging everyone that do the test. Do not engage with someone where they do not know their HIV status. Know your HIV status. Because when you know your HIV status, you tend to be now more careful other than when you do not know your HIV status. So, and you cannot use now the eyes. Test. Yes, test together as we are making the test kits available. And different modalities of test kits.
Right.
Yes.
Right. So, I am very glad that I am talking to you because you said you're basically in charge of adolescents, yes. Right? And those adolescents and
young people.
And those, according to statistics, they are the most affected, especially adolescent girls. Those are girls between 15 to 24 years. They're really affected by HIV/AIDS. And according to your work line, what are some of the reasons as to why we see this happening so much in adolescent girls other than any other demographic out there?
The number of factors which could be biological. You know, biologically a woman is at more risk than the man. But also we have structural and social. So when you look at some of the factors is you look our social setting or cultural setting, which encourages the man to have more women or more wives, and yet the woman is supposed to have one. And also we have the reason that we still have this culture that as a girl, as a young girl, look for a man who already has something, who will be able to take care of you. So that is going to lead to cross-generation sex. And probably even by the time you're going to that man who is already older, one probably is already infected because he has lived longer than you, he's older than you. But also you are not going to, it's hard for a young girl to negotiate for safer sex. Maybe even if you want to use a condom, you'll be at the mercy of the man. If you want to go maybe for PrEP, you'll be at the mercy of the man. How he wants, because between 15 to 24 years, not only the girls, also the boys, but at that time, the girl feels is an adult, is not yet an adult, but they don't have the social skills. You're not socially, like you're trying to develop even an employable skill. If you are employed, it's not a gainful employment, yet you have the needs. And also we have, these days things are being made worse by the social media, which increases the peer. I should have this, I should have a smartphone, I should have that. So you find that girls are engaging in multiple sexual partners. Right. And recently there was a study here which was done by the School of Public Health. The findings just released a few months ago or a month ago, which showed that we are having young girls, even those in institutions, where they have, in a year you can have up to 8 partners. So meaning they're engaging in multiple sexual partners. And most likely the condom use, our evidence has showed, when you look at the recently released Uganda Demographic Survey indicator shows condom use is low. So that means they're having unprotected sex with many men, most likely who are older, who have the money. And also we also have some cultural issues where we have culture, early marriages, early sexual debut, compared to when you look at the boys and the girls tend to engage in sexual behaviors earlier compared to the boys. So all those are the poverty, and then the girls end up saying, okay, let me use what I have, let me use my body so that I can survive. And that's happening even those, for both who are in school and out of school, we are seeing it happening. So all those factors which are driving girls to go into risky sexual behaviors are the ones which are contributing to this, which make up to say that we are seeing more new infections among the adolescents compared to the other categories.
We are seeing more infections among the adolescents. Yes. According to statistics, the adolescent girls are at a higher risk, really. But also, let's go back geographically. Geographically, according to statistics by the Uganda AIDS Commission, we are seeing the prevalence rate higher in cities, you know. And so what is the correlation there between cities and infections? Because according to the recent table, we saw some of the top cities we talked about Fort Potro, Soroti, Mbarara, Kalangala, all these. And at the back of our heads, we're like, okay, so what's going on? Help us understand this.
I just want to first make a difference between a prevalence and an incidence, and you seem to have mixed. Whereas prevalence, incidence is working with the new infections, or the incidence rate, which we are seeing in these cities that it's high. But prevalence works with both the old infections and the new infections. So the prevalence might be higher when the incidence rate is low. Why? Because maybe previously that place or that region had many people with HIV, and you know, once you're HIV positive, you are positive. We don't have a cure yet. So what we are seeing right now, we are seeing a high infection rate among the cities. And the explanation could be because with the cities we are seeing influx of people, the young, the old, but all categories with all behaviors. The most sex work which you are going to see, which is the key driver, because our evidence shows some of the categories, is the sex work, which is, and their clients, they are going to be more in the cities compared to the villages. And you know, the villages, people know each other, but in the city, each one minds their business, the sex work. And you see most of this sex work, when you look at when you break down the age groups who are involved into the sex work, they are mainly the young people. People who are using drugs, and substance abuse, they are going to be mainly in the cities because there's easy access to those drugs compared to the villages. People who are engaging in homosexuality acts, which increases the risk for having HIV, they are mainly, I'm not saying they are not there in the villages, but when you compare the proportion which is in the village and compared to the proportion which is in the city, it's more in the city. And also the demand, the cost of living to a young person in the city is high. I keep telling my colleagues, you know, you can be in the city, you are dying of hunger, you are sleeping hungry while your neighbor is pouring food, which is different from the village. In the village, much as has changed, the villages have changed, but we still see that at least there is concern for a neighbor. But in towns, so you get that pressure to survive, and the cost of living is high, so you end up engaging in risky sexual behavior. So I want to believe that's why we are seeing a higher incident rate among the cities. And obviously now for Kalangala is a landing site, a fisher folk, where we have so many fishermen, and there's sharing of women. The women are scarce there. And there is a saying which says that at the landing site, a man doesn't own a woman, or you don't own a wife. When you're getting out, that is the end of you, that is your wife. Another person who comes in has a right to have as long as you're not there. So that sharing, because the women are few, in case one person or one lady is infected, is going to spread to many men. But remember also those people who are there, they are there for work. After some time, they'll go back home to meet their families. So those are some of why we are seeing the incident rate or the infection rate to be high in the cities and the landing sites.
I see the challenges that come with this, and how do we address some of these challenges, especially when we go back to the adolescent girls? Right.
So the adolescent girls, it comes back, one, we need to give them the messages, the messaging, they need to know. As you already, I think, say that people no longer fear HIV/AIDS. Some believe even do not, some might believe that it's not there. It's for others, but HIV/AIDS does not discriminate. HIV infection does not discriminate. And we still tell them that also making available the different options of interventions for HIV prevention, what we are calling the last mile distribution, that it is there at that spot when and at what time you need that intervention. Like if you need a condom in the night, you know most of our sex here in Uganda or in Africa is not planned. You go to have fun without sex in your mind, but along the way, things happen. So when those things happen, is the person or the two people, are they able to access the condom? Remember, it was not planned. Or if they failed, okay, are they able to access the PrEP? Because an accident has already occurred. But at the end of the day, for what we are telling the adolescents, abstain if you can't, be faithful to one partner, or if you fail, use a condom, in addition to the drugs. Yeah. So there's one method which is going to work it all. And then also what we are seeing is parenting.
Right.
Some of these adolescents, you are 19, or by the time you're joining the university at 18, they think you're old enough, now take care of yourself, and the pressure is piling up on you, and then you end up, and then there is also peer pressure from your friends. You want what they have, at home they are not providing you, but parents or caretakers should constantly have time to communicate with these adolescents and young people and guide them. All of us will have that responsibility.
Right.
Yeah.
And the men also have a responsibility, because on the other hand, the other portion of the demographic that is also really affected is also the elder men. Give us a little more detail about that.
We have another proportion which is being affected is the elder men, and especially those that are 50 plus. But when you look at them, they are those men who are most likely going to test for HIV. They are the men who are not using also the condoms, or they have been in previous relationships.
Right.
Actually, for men who have been in previous relationships, that is either they were married and separated, or they are divorced, or they are widowed. The risk of infection, they contribute about close to 38% of the new infections. So the risk is higher. That means they are not being held accountable to anyone, and sometimes they have, they are not committed, so they end up having multiple sexual partners just for fun, and it's not for commitment. So you find the risk is high, and these are the same men sometimes who are going, they have money, they're already working, they have some assets, they have some money, so they can also lure these young girls. And when you look at our statistics of recent infections, because these days when you test for HIV infection, we are able to tell, has this person acquired this infection within the last 1 year, in 12 months, or it's an old infection as just didn't come for the services. But when you look at the data which is showing us of recent new infections, of all the new infections which are affected, you see that the trend of the age groups for the women is from 15 to 29. For the men, it's 30 to 39. So most likely, these are the sexual partners to these other girls. Remember, also the girl at that age, under pressure, you want to settle down, you want to get married. They're asking you, when are you getting married? Yeah.
I'll ask us to talk a little bit about one of the achievements that you actually highlighted was the mother-to-child transmission rates that have actually gone down recently, and that has been very significant in the fight against HIV/AIDS in Uganda. That is one of the achievements that is actually clearly seen in our communities there, that you find an HIV/AIDS a mother with an HIV negative child or baby, and that is one of the things that we look at as one of our great achievements. But what are some of the key interventions that have actually helped in this progress, and what are some of the gaps that remain?
When you look at our program, which has helped an HIV positive mother to have an HIV negative baby, which we call PMTCT, or Prevention of Mother to Child Program. It's one of those programs and interventions which really, after the evidence showed that it's really possible, we took it up wholeheartedly and then scaled it up to the lowest facilities, but even communities. But also it is we've had campaigns. There's a campaign which was led by the First Lady of the PMTCT to create awareness, sensitization and awareness to communities, to the leaders, to the local leaders, cultural leaders, political leaders, but any opinion leaders within the communities, but also to the mother and the family. So, and then I think it also gave us a good stride towards that, because people came to know that or there is this intervention, and it's actually true, you can be HIV positive and have an HIV negative baby. But also it reduced on the stigma and discrimination.
Right.
Both the self-induced stigma, because sometimes when someone will test positive and you're pregnant, you think, you stigmatize yourself, you don't want to go for services, you feel that is the end of the road, but it gave hope. We also have another campaign, right now we have a campaign which is called Look for That Child. And we are looking for that child. Right. And then the interventions which are involved within that PMTCT program, including HIV testing, I think every pregnant woman or a woman who has become pregnant is aware. They were integrated into the routine services for maternal and child health. That right now, if you become pregnant, wherever you go, whether high upscale facility, hospital or lower facility, which is in the community or health center too, or even an outreach, they will test for your HIV. And immediately you'll be started on ARVs. Even when we have a shortage of supplies, we prioritize the pregnant woman. So I think those are some, the commitment, the competence, the availability of supplies and commodities, and also the awareness that the women are able now to demand for the services.
So tell us a bit about Ugandans' goals in reducing the HIV/AIDS infections by 2030, and how realistic is this target really?
Our Ugandan goals are within the Presidential Fast Track Initiative. It highlights the goals, there are mainly 5, and how we can achieve it, because other countries, our neighboring countries, in African setting, our neighbors here, you can look at Rwanda, you can look at Kenya, you can look at Israel, they're all doing better than us in terms of new HIV infections. So meaning we can do it, they are not unrealistic, but all need concerted efforts for us to achieve. So you look at our first goal, which is reach the men with HIV prevention, and also tap and reduce the type of new HIV infections among the adolescent girls and young women, who are even contributing almost 1/3 of the infections. So if we do that, we reach, the men are the ones who are infecting the girls, because most of our infections is not mainly from blood transfusion or needle stick injuries, it's mainly sexual. So if we tap those new infections, look at the male partners or the female partners, profile them, get to know the characteristics, who are they, how do we reach them, what are the risk drivers, then we can really affect. So we also have like accelerating the test and treat, which we've talked about, to ensure that each one of us know our HIV status. And if you're HIV positive, you go on the drug, you start the drugs and adhere to the drugs, not on and off. So once the viral load is reduced, you're able to live. But we think also when you have the viral load which is reduced, the risk of transmission is also, in case of an accident, the risk of transmission is reduced. We also have to accelerate our PMTCT interventions to sustain, because we already know, we have the evidence that the program is really working, the interventions put in the other programs which are within the program are working. So we just have to scale up and sustain those best practices. Then financing, we acknowledge that it's donor funded, as we already talked about it, increase on the domestic financing towards the HIV program, and also reducing the stigma and discrimination. So when you look at those targets, there's no, it's not that it's one, you see they're all related, but if we work towards them, they're achievable. They are realistic, they're not from the moon. Yeah, they're for us here, they are realistic and they're achievable.
Right. And what can individuals and communities do to support the fight against HIV/AIDS?
The individuals and just know, as I've already said, that it's a concerted effort. It starts with a person at an individual level. Avoid the risky sexual behaviors. The most important thing, we are going to remain on the basics. Abstain or be faithful to one partner. And then now we can add on the condom use and the use of the drugs if the other two have failed. The community, we need to be supportive. So individuals take a responsibility, know your HIV status, test. If you're married, go and test with your partner. Don't assume that your partner's status is your status. We've heard of discordance where someone can be positive, another one is HIV negative. So know the status, Let's support our friends, let's support each other. For those who are HIV positive, to take the drugs, to remain on the drugs, remind them to take the drugs, and reduce on the stigma. Yeah. So as a community, we also have to have that, encourage each other, be a supportive community. We shouldn't discriminate people because of their HIV status. The employers, we shouldn't discriminate. And also support, when they bring the services for the HIV, let's embrace them and support people as a community to take up the services or the interventions which have been proven to work.
Right. And then finally, as we close off, you could give your final remarks as we commemorate the World AIDS Day today. You could give us a word, especially to people living with HIV/AIDS and their families.
As we are closing, people who are living with HIV/AIDS, I would recommend positive living. Let's live positively, let's take responsibility, let's remember to take our drugs, let's also care for the others. And also the people who are caring for those who are HIV positive, let's not stigmatize, but instead let's be supportive, remind people, support them to go to the health facilities, to follow the advice of the health care provider, to swallow up their drugs. So, because you do not know, today they might be yes, you do not know who tomorrow they are going to have maybe unprotected sex with. As Phile Bongole's song says, today it's me, tomorrow it's you. So tomorrow, either today I'm the one who is infected or affected by HIV/AIDS, tomorrow it's in another family. But we need support. Psychosocial support is still important. Nutritional support is important. Provide, because nutrition is also equally important as well as drugs. You are not going to take them on an empty stomach. So each one of us has a role. So let's join hands, let's work together, let's support each other, and we shall be able to achieve our goals. But most importantly, know your HIV status.
Well, thank you so much, Dr. Maureen. It has been nice having you. Thank you for the very insightful discussion there. And I believe someone out there has been helped one way or the other. It has been nice, really.
Thank you.
Well, and we come to a close of the weekend edition this evening. It has really been nice having you. And as we discuss and we commemorate the World AIDS Day, just like Dr. Maureen has said, let's be there for one another, let's support one another, and let us just make sure that you know your HIV/AIDS status. That's the first step of fighting HIV/AIDS in Uganda. Well, until next Sunday, I'll see you then. For now, do have yourself a wonderful, wonderful new month ahead and a wonderful week. I am Nora Sende. Good night.